So, three-dimension tunneling from buccal side, from lingual side, and interdentally is also a split thickness technique. How is done? Always clean root surface. Before the surgery, I go with the prophylaxis, with the powder, erythritol. This is the mani. This is 1 millimeter width ophthalmic blade from Mani, Japan. Intrasulcular, a normal tunneling, the buccal tunneling. This is the bendable blade, SB003 from MJK, it's French, and you bendle it. It's also pretty sharp. You continue your tunnel. There's nothing new here. It's a split thickness buccal tunnel. Then you go with the lingual tunnel. Now, to do the lingual tunnel in the mirror is difficult. It's better to choose the patient that is opening the mouth widely, so you go with the direct approach. After this, you connect these two tunnels with the Mani blade, with the split thickness, interdentally. Then you take again the palatal connective tissue graft, extraoral depitalization. I like to take the graft in one piece and then to cut the part that goes interdentally. You first introduce the interdental graft, and then you introduce the buccal graft. Here is the same way to introduce the graft as in Suzuki. And in tunnel, we put the graft the same way like in a normal tunneling with the suture. You have to know that where you place your sutures, okay, the graft should be 1 millimeter below the gingival margin. Where you place your suture to introduce it, it will stay there. So plan this. Then the double cross suture that is going through the buccal flap, interdental flap, lingual flap, all together, is catching all. And is moving all these tissues coronally. For this suture, in most of the times I'm using 5-0 polypropylene. And then you go with, can be, or composite sutures, as here, to pull up also where you don't like the position of the mid-facial border. And same thing you can do also lingually. I propose you to start to prepare yourself for the 3D tunneling just with a simple lingual tunneling, where you have a patient with lingual recessions, opens the mouth big, do a lingual tunneling, prepare for it, because it takes more time than all the rest. And those are the steps for the 3D tunneling. And in the end, we put the M again. Now, the idea of the 3D tunneling is to not to close the buccal recessions or lingual recessions, but is to move all this tissue coronally and to keep it there without tension. That's why I'm doing the buccal and lingual tunneling as well. Okay, to move the interdental tissue coronally and to keep it there without tension. And my goal is to get the papilla. If I also simultaneously cover buccal and lingual recessions, okay, is additional. For me, it's important that the 3D tunneling is the only technique that gives you the papilla in the lower jaw. Because in most of the times, in lower jaw, you don't have this amount of attached gingiva to do Suzuki. So, step by step, again, intrasulcular buccal tunneling, connecting this. Okay, you see how thick I stay with the flap? When you see in transparency, your instrument is already 1 millimeter. Lingual tunneling, okay, this is the hardest part. Each instrument that works for the buccal tunnel doesn't work for the lingual because of the axis. For the lingual tunnel is much easier to work with a straight blade. And if you are able to do it intrasulcularly, bravo. Sometimes I'm helping myself if I cannot make an axis and it's risky that I rough the border. I'm helping myself with the vertical cut, like this. Okay? I'm helping myself, so that's how I can introduce the bundle. This is the TKN2, the one that I use for buccal tunneling. And I'm connecting in most of the times. It makes my job much easier. Sometimes I'm even adding this cut also buccally. It helps me with the tunneling itself. That makes it faster. And then you connect interdentally, and this is the hardest part because you have to see what you do. In Suzuki, it's more visible what you do here. Here, you have to help yourself with the probe or with something non-cutting. Opening it, your assistant is making it dry, and you see where you split. Then you check the mobility if it's not enough, in your opinion, because during this check should go the papilla where you want it to be already, without a strong tension. Then you move more apical with your tunneling. Okay, you mobilize until you're happy. Usually it looks like this. You turn, you see, I already split it here. I turn below the papilla and I move it up. I check if I like it or if it's not enough. Each papilla is split. The one that you graft, you split. If you raft the papilla during this procedure, don't graft it. It will be okay, it will heal, but don't graft it. If the splitting is well and so on, then graft the papilla. Then you take all in one piece, you separate, the interdental part usually has a square form, and where to place the graft. You remember this classification that I showed you. According to this classification, it's easier to understand where to place the graft. For example, sometimes when there are no buccal and lingual recession, it's just a lost papilla, or when buccally has been already grafted with the normal tunneling or cuff, and is already thick, I do not graft buccally. And the same about the lingual side. I graft only interdentally. Still, I do all this 3D tunneling approach. So I do all this tunneling just to move the tissue up, but I graft only interdentally. If I can simultaneously make the buccal tissue thicker, close the buccal recession, I'm placing also the buccal graft. You have to know, more grafts that you put, more risky becomes the procedure. And just once in my life, I did 3 grafts. It was a bad healing. So the type E almost never exists. When you place all 3 grafts in one surgery, you can do steps. You can do buccal graft and interdental. The next step, again, interdental and lingual, and then you see if it's enough or not. Of course, it's harder to introduce the lingual graft because you work hopefully with the direct view, but sometimes you work in the mirror. Plus, second thing is that the patient should open widely, very widely, and the teeth should not be inclinated lingually. You have to see the gingival border lingually on the lower teeth. You have to see it. It's not that it's closed by the crowns. So this is more or less the plan of what we do. For example, here, the buccal flap has been done already, the normal tunneling by my colleague. With the buccal grafting. It's thick, as you see by this instrument. It's thick. We don't see, it's very thick. We don't see the blue. So why should I, even when there are buccal recessions, why should I graft? The tissue is already thick. I will move it up, okay? And I will graft only interdentally and lingually. So yes, these are the steps. Let's see how it looks like in reality. For example, this patient, she had recession type 2, as we know. Actually, she had a stage 4, but just because of, I think, the quantity of extracted teeth. I don't remember why it was stage 4. In fact, it was looking more like a stage 2 and grade A. Periodontitis that has been treated, the non-surgical part and so on. This is the result of this when we start the surgery. And by the papilla class, defect is type 3, so it's lost all the tissue, E. So we don't have anything. We don't have buccal papilla, interdental, and lingual. This is the situation. And she doesn't have, in the Excel view, again, my favorite view on the Kaminsky scan, she doesn't have the buccal bone wall, okay, which is normal, especially for the girls. Until the middle of the lower incisors roots, there is no bone. And we do the 3D tunneling. What I want to show you is in each case that I did a 3D tunneling, even if before was no tension of the frenulum insertion, of the muscle insertion and so on, in most of the cases after the 3D tunneling, because the tissue then maturate and they grow, they make thicker, sometimes mucosa doesn't stretch that much, doesn't grow. So it starts to arrive the tension. And you will notice it after 2 months after first surgery. You will see the patient and you will notice that there is a little bit, you move the lip and you see a little bit white area of papilla that you want to grow. And at the second stage, here in this particular case, we placed a lingual graft as well. This was the lingual situation. It was opening widely and so on. This retainer has been placed only for the sutures. Healing buccally after 2 months. You see the tension, and this is after the frenulotomy. So I made a frenulotomy after 2 months after first 3D tunneling. This is before frenulotomy. Look at the papilla. This is after. Okay? So I haven't grafted more here. And then what is interesting to notice for me, because this patient has been sent by orthodontist. They wanted to do orthodontic treatment. She had a bad occlusion and so on. They started ortho with Invisalign after 8 months after surgery. Look, they're moving the teeth. Now, look, this is after 8 months. They start the ortho. And please focus on the papilla between the centrals and laterals. This is how much they lost the papilla where we're not grafted. But even opening the space a little bit, the attachment is still there. Because you give to the orthodontist the patient only when it doesn't probe. It's not that we gained aesthetically the papilla, we gained the attachment. That's how the orthodontist, a little bit more slower, can move the teeth without damaging this attachment. And I'm secure about the position of this papilla. So we will have then later to graft the distal papillas. This is 1.5 years after surgery and 1 year of orthodontic treatment on Invisalign. This is before and after, 8 months, 1.5 years. You see, it continues to grow, even though it was palatal connective tissue graft. And what I like to show here, again, is not about aesthetics. It's about attachment. She has 4, now is 2. We gained 2 millimeters of attachment.